etiology of this sexual dysfunction, management strategy, so how to deal with sexual dysfunction induced by the antidepressant treatment, and then we'll finish the presentation. So just to give you a brief overview of how common antidepressants are, it has been over 264 million prescriptions filled for antidepressant in the United States population. So it's one of the best, if not the most prescribed drug overall. The SSRIs have a very simple mechanism of action. Basically, they block the SERT, which is the serotonin reuptake transporter. They basically kind of polish the synaptic cleft in order to sort of block the serotonin transmission. And that's why SSRIs, they basically block the SERT, and they basically increase the concentration of serotonin, allowing for a better transmission, a more powerful transmission, and a continuate transmission. That's not the sole mechanism of action. In fact, this is what happens at the synaptic cleft. But at the body of the neuron, basically they interact with another type of receptor, which is the 5-HT1A receptor, which is basically an inhibiting receptor. But basically, with a continuative therapy, what happens is basically an underproduction of this specific receptor. So by blocking the inhibition, you basically have a potentiation of the effect. So basically, the coupling of the two, so the blocking of the SERT plus the underproduction of the 5-HT1A leads to a high and potent serotonin transmission. Serotonin reuptake inhibitors has been used, are used actually for a bunch of conditions, of course. What the first and foremost is depression, is major depressive disorder, but it has been used, of course, for anxiety and for eating disorder. These are all FDA approved. It's been used also for PTSD, but not all of those, mainly sertraline and fluoxetine. It's been used also for vasomotor menopausal syndrome. It's also FDA approved. Premenstrual dysphoric disorder, and last but not least, of course, also, as we have seen in the last few presentations, also for premature ejaculation, mainly paroxetine. But there are many other uses which are not on label, they are off label, and one of those is migraine prophylaxis, it might be body dysmorphic disorder, impulsive control disorder. They have low quality evidence, but it's been recorded that can be used also for this condition. This is Vietnamese, okay. So basically, there can be a lot of side effects among SSRIs. So, for instance, this is just to give you a brief overview of what Zoloft, which is sertraline, may do. In the first week or two of treatment, they basically give nausea, they basically give confusion, fever, agitation, even the worsening of the psychiatric symptom that this patient has been treated for. So that's why you have to basically instruct the patient to stick to the therapy. Otherwise, one of the commonest things of these patients is that they will basically drop the therapy because they cannot take it anymore. They will feel that they're feeling worse. And if the long-term treatment continues, what you basically get is one of the main side effects of this treatment, which is the sexual dysfunction. So if you're familiar with the concept of effect size, so basically it gives you the proportion of how much a certain therapy, for instance, might have on a certain condition. And sexual problems have a higher effect size than for treating depression. So that's why these type of drugs should not be ideally called as antidepressant, but rather sexual dysfunction. And to give the epidemiology, 50 to 70% of the people under treatment of SSRIs develop a sexual dysfunction that may be either low or very, very high. There can be an impact in multiple phases of the sexual intercourse. There can be an impact in libido, there can be an impact on the arousal, and even on orgasm and on the ejaculation phases. So all the phases are affected. What does can lead this particular condition? Well, actually, of course, it can cause an early discontinuation of the antidepressant. So sexual dysfunction, this is not the sole case, the sole psychiatric drug that can lead to sexual dysfunction. But sexual dysfunction is one of the first predictor of therapy discontinuation, and this is exactly the same among antipsychotics, and in some cases also benzodiazepines, and stimulants, for instance. Cocaine is another, although it's not a psychiatric drug, but it's a stimulant. Methamphetamines can lead definitely to a sexual dysfunction, which is one of the main predictors of early discontinuation. And of course, if one can discontinue the therapy, it will lead to a relapse of depression, and last but not least, a poor quality of life. Again, this, especially the last one, is another predictor of early discontinuation of the antidepressant. Not all of the serotoninergic antidepressants, well, basically, not all of the antidepressants are able to cause a sexual dysfunction. We have multiple molecules. Some of these are not SSRIs, but have a serotoninergic declination. In fact, have a high and potent serotoninergic tone. The tricyclics, for instance, are one of those. They're not impacting only on norepinephrine, but they're also able to impact on serotonin. Some very highly, some other not very highly. So, for instance, clomipramine, which is one of the main tricyclic agents, it's very able to impact on serotonin tone. In fact, is one of the first tricyclic to cause a sexual dysfunction. Mayo eyes, again, trazodone is not, well, is unknown, but it does cause a particular sexual dysfunction. Trazodone basically blocks the 5-HT2C receptor, which is, again, another type of serotonin receptor, and it's able to cause a particular sexual dysfunction, and that's why it's mainly used to treat other sexual dysfunction, and this particular sexual dysfunction is priapism. In fact, in America, it's also being called trazobone. SSRIs, of course, have a high, as we were saying before, has a high prevalence of sexual dysfunction, again, from 60 to 70% of the cases. But when we are actually going to, for instance, mirtazapine or agomelatine, which does not have any, let's say, serotoninergic or prevalent serotoninergic action, agomelatine is acting basically on other type of receptors, and mirtazapine is another one of those. It's mainly acting on alpha-2 norepinephrine receptors rather than serotonin receptor. You can easily see that the prevalence drops down to 25% or even less than 20%. Whereas venlafaxine and duloxetine, venlafaxine in particular, it's able to cause a sexual dysfunction in 70% of the cases because it has a high and potent serotoninergic tone. This is just another graph that allows you to basically have an overview of what molecule is basically giving the probability of developing a sexual dysfunction. So agomelatine, again, is the second. Moclobemide is another one. And 0.25 is basically the odds ratio, so the probability that a patient who's taking that particular drug will develop a sexual dysfunction against another patient who's not taking that specific drug. But if you go up to sertraline or venlafaxine, you go 27%. So basically, a patient who's taking sertraline will have 27-fold higher probability of developing a sexual dysfunction compared to a guy who's not taking that specific drug. So it's very high. Recently, it has been there has been raising attention to another condition, which is basically PSSD. Why is it so important? Because what we have seen so far is the fact that while on drugs, you basically develop a sexual dysfunction. But as soon as you drop that specific drug, you're supposed to finish, that specific side effect. But with PSSD, which is post-SSRI sexual dysfunction, you sort of continue having that specific sexual dysfunction, which is a major concern for multiple patients. And this comes with a bunch of sexual side effects, and these may feature genital anesthesia, anorgasmia and delayed orgasm, but the first and foremost also a particular symptom, which is the disconnection between brain and genitals. So basically they feel kind of disconnected. PSSD again has been clarified and has been codified by this article. And for having a diagnosis of PSSD, you basically need to have a prior treatment with serotonin reuptake inhibitor, which is not, again, only SSRIs, but also SNRIs or tricyclic agents, and an enduring change in somatic or tactile, again, for instance, the sort of anesthesia that this patient have, or erogenous sexual, in particular, genital sensation after treatment, after that the treatment stops. There can be also additional features, so for instance, a reduction or even a loss of desire, loss of libido. There can be an erectile dysfunction, there can be the inability to reach the orgasm, and so on and so forth. Well, actually, this is not the sole case in which you have this specific symptom. This beautiful article says that there is actually another condition, which is the post-finasteride syndrome, which features exactly the same set of symptoms. So this is the incidence of self-reported brain disconnection, which again, if you recall, it was one of the main features of the PSSD. And this is, again, the lack of libido among the two conditions. But finasteride, you probably know better than me. It's basically an agent that blocks the 5-alpha reductase, which is able to basically turn and produce more testosterone, the dehydroepiandrotestosterone. So that's why we had the intention to basically study that specific condition from a psychiatric point of view, since there have been multiple communalities between these and other diseases, which are, in most of the cases, rare diseases. So another is the post-isotretinoin condition, which feature exactly the same set of symptoms. We tried to study also, besides symptomatology, also personality, attachment style, of course, sexual dysfunction, and somatoform disorder. So basically, we're trying to sort of recreate a psycho and psychiatric perspective of that specific disorder. So PSSD, well, actually has some declination, because the most common case is basically SDDS, which is the sexual dysfunction prevalent while on drugs, but it drops as soon as the therapy drops. PSSD1 is basically the PSSD that continues, that you have a sexual dysfunction that continues even after the therapy drops. And this is the more rare one, which is no sexual dysfunction while on drugs, but after you drop the therapy, you basically develop asexual dysfunction, which is a particular rare case. The most common one is the first one. The second one is PSSD itself, which basically a sort of continues after the therapy drops. And the third one is the least prevalent one. So just to give you sort of an idea of what is a PSSD, this is a brief case report taken from the literature. Basically, this is Mr. M, who has been treated with venlafaxine for burnout, with depressive symptoms. This guy has been developing brain zaps, sweating, and bladder problems. And that's why he wanted to discontinue the drug, but he was not able to basically stop, because these symptoms were heightening quite a lot as soon as the guy was trying to stopping this particular drug. But after 5 years, he managed to basically stop it. And what he got is basically an extremely strong erection and orgasm while aroused. After some months, he basically start developing other type of symptoms, which were sexual symptoms, of course. But these symptoms, which were the previous ones, sort of aggravated, so there were not strong erection, but rather an erectile dysfunction, shrinking of the penis, anorgasmia, delayed ejaculation, and reduced libido by 90%. This, again, is one of the most common presentation of a guy with PSSD. The symptoms have persisted for 10 to 12 years, and he's not been receiving any diagnosis, but he started to do some blood tests. But what you can, from what you can see here is basically that all the bloods were fine except the dehydroepiandrosterone, which were basically quite low. But apart from that, he was fine from a blood perspective. He started to do various treatments, but none of them were efficacious. Oxytocin, L-tryptophan, which is a precursor, of course, of the nitric oxide, testosterone, and other supplements, but none of them had a particular action. So how is that? What is the mechanism of serotonin impacting on sexual function? Basically, one of these is the impact on dopaminergic tone. Again, we were talking about this yesterday. Dopamine is one of the main reasons of why people respond to sexual stimuli and why people have a sexual motivation, because it basically mediates the response of pleasure. And dopamine pathway, in particular the mesolimbic pathway, is the one that goes from the ventral tegmental area up to the basal ganglia, and in particular to the nucleus accumbens. Well, serotonin, via the use of 5-HT2A, which are inhibiting receptors, it's able to basically modulate the dopaminergic tone, leading to what has been defined as a loss of libido. But it's not it's not the only action that serotonin has on sexual function. In fact, it's able to also sort of reduce, and we'll see in the next few slides, also the production of testosterone and sexual hormones in general, and thus leading to another decrease of desire. It's also able to have a peripheral action, in particular on sensation, and that's why it's supposed to these people are supposed to develop genital anesthesia, and also on the production of nitric oxide, so a reduction of the nitric oxide, which is, again, of course, one of the main leaders to the penile engorgement. What is the neurobiological explanation of this? Well, basically, as I said at the beginning of my presentation, serotonin is able to interact with the 5-HT1A receptor, which is an inhibiting receptor, but via a chronic stimulation, you basically get a reduction on the production of this specific 5-HT1A, leading to a higher stimulation of the synaptic cleft. This is one of the proposed explanation of why serotonin is able to impact on erection functionality. Basically, the paraventricular nucleus up in the hypothalamus, it's able to interact with the raphe nucleus, which has multiple serotoninergic neurons, which expose on their surface also serotonin receptors, and one of those is basically the 5-HT1A again, which is able to impact on the erection by inhibiting the erection. It's also able to basically reduce the production, the transcription of a gene which is supposed to produce the eNOS, which is the nitric oxide synthase. So this is basically the action on the translation. This is basically a Western blot showing how much citalopram is able to reduce the production and the translation of the eNOS, the nitric oxide synthase, thus leading to a lower amount of a lower concentration of nitric oxide in the bloodstream. This is another explanation of why serotonin may also act on ejaculation itself. In fact, the 5-HT1A is able to sort of shrink the latency of the ejaculation, but as you can remember from the first slides of my presentation, SSRIs are also able to under-regulate the 5-HT1A receptor. And that's why you basically get an increase of the latency of the ejaculation. And that's why these type of drugs have also, can also be used to treat premature ejaculation. The exact proof of concept of what I just said is this specific molecule, which is the 8-OMe-DPET, which is basically a full agonist of the 5-HT1A receptor, which again, it's the one who's been thought to be responsible of sexual dysfunction. And in fact, all the rats that were treated with this type of molecule developed a reduced ejaculation latency and reduced intromission preceding the ejaculation. Another explanation of why this set of drugs are able to cause ejaculation dysfunction and erection dysfunction is because they are able to impact on oxytocin. Oxytocin, again, it's one of the main actors of erection functionality and also ejaculation functionality, because it's able to basically improve the erection and shrink the latency of ejaculation. So since the serotonin leads to a decrease of the concentration of oxytocin, it will also lead to a decrease in the potency of erection and plus also the increase of the ejaculation threshold. Again, the same molecule, 8-OH-DPET, which again is a 5-HT1A agonist, is also able to interact with the production of the gonadotropin, and in particular with LH and FSH, thus leading to, at the end of the stream, to a reduction of testosterone, estradiol, and DHEA. But are there other explanation of a sexual dysfunction, of an SSRI, post-SSRI sexual dysfunction other than the neurobiological or neurophysiological explanation? Where they could be, in fact, these people while on drugs, since they will have a sexual dysfunction, they will sort of develop a negative condition towards sexuality and towards sexual activity. So basically, even after they drop the therapy, they can experience a sexual impairment, mostly because there is a sort of anticipatory negative expectation, anticipatory anxiety, and anticipatory depression. So cognitive and psychiatric symptomatology may also explain the onset of sexual dysfunction even after the dropout of a specific SSRI treatment. Can we manage this condition? Well, it's not very easy, actually, and most of the therapies that you will see in the next few slides have a very, very, very low effect size, and they're not very efficacious in the overall condition. One of these is basically watch and wait. So wait for spontaneous resolution. It has been demonstrated that only up to 20% of the cases will resolve within a certain amount of time. So basically you stick to the therapy. Although this patient will complain about sexual dysfunction, you basically reassure the patient, and the sexual dysfunction will vanish by itself. But this happens only on 20% of the cases, meaning that the other 80% of the cases will probably discontinue the therapy. Drug holiday, this is something that us psychiatrists will not want to see, because if you basically drop the therapy, the patient will be certainly decompensated. And in fact, the mostly prescribing guidelines do not prefer this strategy, and they don't want you to do it, actually. Even though there are some evidence, even though there are early evidence showing that some patients will benefit for this strategy. Decrease the dose. This can be done if the patient is well compensated, if the patient is not needing any, a high amount of dose of serotonin. But if you, again, have a major depressive disorder, which sometimes have other psychiatric symptomatology, or even a very, very high and very worse OCD, well, even decreasing the dose will not be a possible management strategy. But again, there are some evidence that even by reducing the dose, there can be a moderate action on sexual function. These are definitely another possible strategies that have much more evidence than the previous ones, and in particular the switch with other more sex-sparing molecules. And these are the ones that I was talking about in the first slides, the ones that are not actually acting on serotonin. And bupropion is definitely one of those, because it's a blocker of not only norepinephrine, but especially dopamine, which again is mainly the main neurotransmitter dedicated to pleasure. And there has been a bunch of evidences that if you switch from an SSRI to a bupropion, you basically have a good outcome in terms of sexual dysfunction. Mirtazapine is definitely one of those. Oh, by the way, these drugs carry other types of side effects. So, for instance, mirtazapine will definitely lead to a weight gain. So use them if you have the chance to with concern. Agomelatine is definitely one of those, because it acts on melatonin receptors, so it's not supposed to act on any serotonin, but it does come with a possible liver injury side effect. There can be also augmentation strategies, again with the same set of molecules, bupropion, mirtazapine, agomelatine, next to the SSRIs. You can use, of course, antidotes, so phosphodiesterase 5 inhibitors or other strategies that we'll see. Sildenafil is another one of those. Buspirone. Buspirone, basically, it's a molecule that is not used, well, it's used, it's commercialized, but it's not that prevalent among the therapies. I mean, in Italy, we tend not to use it very much. It has been used for anxiety disorder, general anxiety disorder, and it acts on the blocking of serotonin tone. And there has been some evidence of buspirone, which is not bupropion, of course, on the healing and on the improvement of a sexual dysfunction, of a PSSD-induced sexual dysfunction. There are a bunch of, traditional and alternative remedies. One of those is ginkgo biloba. Ginkgo biloba, you probably know better than me. It's a root, it's a specific plant used in the Chinese traditional medicine, but there can be other side effects. It tends to improve asexual function, but it comes with other side effects, and one of those is the ability to interact with multiple other psychiatric medication. Another one is the maca root. Maca, although it can lead to an increased sexual desire, it's also able to produce this other compound, which is the MTCA, which is basically a mutant compound. So it's very dangerous to use it. Another possible strategy is basically instruct the patient to have a 30 minutes physical exercise before the sexual intercourse. It can lead to a good outcome, but there can be also a high dropout rate because it can be very, very stressing. So that's why we tend to combine all these remedies in one single go. With a bunch of patients, 12 patients. We try to give life advice. We try to give also a psychological support, in particular CBT. We gave them we gave them antidotes, and in particular PDE5 for erectile dysfunction inhibitor, and buspirone for hyposexual desire disorder. Plus also supplements, and in particular L-arginine, which is a precursor of nitric oxide, to see if they can improve the PSSD symptom. And what we have seen was that there was an improvement in all domains of the sexual function, from sexual desire to overall satisfaction. However, there are some caveats to bear in mind, and one of those is the fact that it's a very low sample size, only 12 patients. So there should be, of course, other and further trial with larger populations. So that was my last slide. I hope you enjoyed. And if you want, I'm more than happy to respond to any questions. Thank you very much.